and palate. There are about 1 to 2 out of every 1,000 children that are born with severe to profound hearing loss. And then conservatively, there's another 2 to 5 out of 1,000 children and teenagers with single-sided deafness, as these kids are usually picked up later in school age. This slide is really just to kind of talk about the different causes of hearing loss. I'm not going to go into the minutia except to show that kind of incidence at birth, there's about 70% of the causes are genetic, and that actually decreases to about 50% by the time that kids reach about 4 years of age as more etiologies arise for causes of hearing loss. So how is this impacting our patients? How is this impacting their lives? I think one of the biggest things is sound awareness. It's a safety issue for kids, even just crossing a street, being able to hear oncoming traffic. We also know that childhood hearing loss is associated with speech and language delays, low literacy, decreased educational attainment. They have a higher likelihood of school dropout and restricted employment opportunities, leading to decreased earning potential. In fact, compared to children who are delayed diagnosis and treatment, those that are appropriately identified and intervened on before 6 months of age perform up to 40% higher on language and social adjustment scores. The cost to society is huge when these kids are untreated. It's roughly $1 million per child. And ultimately, only 36% of infants that need a cochlear implant actually receive them. So why is this problem so pervasive? We need to start thinking about the barriers to care for these patients. And we talk about having a universal newborn hearing screening in the US, but it's not quite universal. The legislation is variable by state, as kind of shown in the map in the bottom right-hand corner here. There's 12 states that don't have a specific mandate, and it's very similar to how COVID was handled. It's a state-by-state issue in terms of how we deal with universal screening. As a result, there's over 500 hospitals that are not screening for hearing loss, and ultimately about 1 million babies are not screened each year prior to discharge. So within this backdrop, we actually had really good news from the FDA about a year ago that reduced the age of allowed cochlear implantation from 12 months to 9 months after showing that it was effective kind of off-label at a lot of different institutions. And it's very important for these kids because they're able to pick up auditory awareness of different sounds at levels within the normal range much earlier. They ultimately have improved speech understanding, sound clarity, and language skills. They do better in noise, and they have better quality of life and educational outcomes. 80% of the children who are implanted before 12 demonstrate receptive vocabulary knowledge that's within the normal range by the time that they reach school entry. So to adequately address the problem, we need to understand what the standard is. And the recommended standards by NIH, JCIH, and the American Academy of Pediatrics is that we diagnose hearing loss before 3 months of age. The kids are aided by 6 months, and if they're still not having any progress, they should receive a CI by 12 months of age. Unfortunately, in 2014, about 60% of US infants failed to obtain a diagnosis within the 3 months after an abnormal screen at birth. So again, why are we failing? Why are we seeing these kids later? We know from much of the data out there that kids that are implanted before the age of 3, which is kind of seen as the critical period, do a lot better than those that are implanted after. It's not to say that those that are implanted after don't do well, but they don't do as well. So one of the barriers that's kind of been discussed is kind of where you live and how that impacts your care. So one group out of Kentucky has been looking a lot at this. And they found that in regards to delayed identification of hearing loss, children living in a rural area were diagnosed almost 9 months later than their urban counterparts. If they failed their newborn hearing screening in 1 year, they had an odds ratio of almost 1.5 of just being lost to follow-up. and that actually increased to an odds of almost 2 if they failed in both ears, compared to rural children. The same group did another retrospective review looking at 40 children who received a CI and were born with congenital sensory neural hearing loss. They found a linear relationship between distance to the implant center and timing of both hearing aid amplification as well as cochlear implantation. And in terms of even early implantation, only a third of those from rural areas were implanted before the age of 2, and compared to about 55% of those from an urban area. Their third study was looking just at access to hearing aids and hearing rehabilitation. The barriers that they saw in this study included lower socioeconomic status, insurance type, public versus private, as well as level of parental education. For this study, they had 35 patients, 21 in the rural area, 14 in an urban. And again, distance was a significant barrier to audiology services, worse in the rural area. In fact, only about 10% of rural children were able to access speech therapy services at the time of diagnosis, compared to 42% of their urban counterparts. And again, this is really highlighting the need to kind of think about why these patients are having delayed care. How can we better intervene? Because ultimately timing really matters for these children. So as I kind of just talked about, insurance type has been discussed as a possible barrier. The group out of Case Western sought to evaluate whether or not this was still the case in an area that they felt they had adequate Medicaid reimbursement. And while in their study, they showed no difference at age of implantation, regardless of socioeconomic background, kids that were Medicaid insured missed substantially more follow-up appointments and more consecutive visits compared to privately insured patients. And this discrepancy with follow-up illustrates that there are additional barriers to care than purely financial that we really need to understand about this patient population. So to attempt to kind of potentially identify more specific reasons for delayed care, at the University of Iowa, this was done in, I think, 2019, they looked at 59 kids that were implanted both before and after age 2. And of the children who had their hearing loss diagnosed within the newborn hearing screening, still 15 of them were implanted after the age of 2. The 5 children in their study that didn't undergo a newborn hearing screening were all implanted late. And then they found that the most common reason for delay cited was actually parental delay, which I'll kind of get to a little bit later as well in a study that I performed, that we saw something very similar. In this category, they had 3 children who kind of came from more abusive or negligent homes that were later actually removed from their parents' custody. They had another child who missed multiple appointments because, as they noted, the parent kind of lacked an understanding of the impact of the child's hearing loss would have on their development. And the 5th child came from a single mother household and who wasn't able to afford the travel necessary to bring their child in for appointments. Their next most common were those kids that actually had a false negative newborn hearing screening, but they didn't have a reason as to why that occurred. And then again, more recently, in 2020, there was a new paper out of Hopkins that was looking at the impact of race, primary language, and insurance type on early access to hearing aids. They looked at 90 patients who were referred for ABR and evaluation for hearing aids at their center over a 14-year period. In their study, about 86% of the patients were white, and it was an even split between private and public insurance. They found an increased delay of almost 7 months from positive newborn screening to ABR for both insurance type as well as white versus non-white race. While the association did disappear between the interval between ABR and dispensing of hearing aids, this study really, again, begins to teach us we need to be thinking about insurance type, race and ethnicity, primary language, and how they might impact a child and how they ultimately access care, because it has real significant clinical implications. So finally, this year, actually, the group out of UCF sought to evaluate the likelihood of having an early cochlear implantation in the state of Florida. This was looking at 385 kids implanted before the age of 2 over a 13-year period using the State Ambulatory Surgery and Services database. They found that actually Black children, Hispanic children, and children with Medicaid were significantly less likely to be implanted before the age of 2. And even with private insurance, both Black and Hispanic children were less likely to be implanted early compared to even white children with Medicaid. They found even greater disparities when looking at those kids that were implanted before the age of 1. In fact, 6.4% of white children were implanted before the age of 1. It did increase to 27.4 before the age of 2, compared to Black children who none of them were implanted before the age of 1, and only 12.7% were implanted before the age of 2. So it was kind of within this backdrop that I took on a study when I was in residency, trying to find out why these kids were being implanted late. So we looked at all kids that were implanted after the age of 3 at NYU and excluded all children with progressive or sudden hearing loss to see what were the barriers to their care. Ultimately, we had 31 patients with a mean age of hearing aid dispensal at 2.8 years and cochlear implantation a little after age 6. We broke down these groups of patients into 4 different categories for reason for delayed care. The first 2 that I've bolded were the 2 that we felt had room for intervention and improvement. They were kids that were continually prescribed hearing aids, even though they were more appropriately met criteria for cochlear implantation, and kids that were not subject to newborn hearing screening. The other 2 groups were those that were aided appropriately and referred in a timely manner, and those with indeterminate records, of which there were 2. So as we took that more granular look for reasons for delay, we had 13 patients within this group that we kind of, again, categorized into 3 subgroups. The largest one that we saw was family dynamics, as the majority in this group were delayed because of some sort of family hesitancy. In the probably most common reason given was some sort of cultural stigma that the family associated with hearing loss. We had a handful of children that were first generation, came from very religious backgrounds, and their parents saw hearing loss as a disability that they wanted to kind of hide. And I think the thought of needing a hearing aid or a cochlear implant kind of made that disability visible. And that delayed care for about 3 of the patients. Denial of diagnosis we saw repeatedly as well. We had one example where a child failed their newborn hearing screening, was actually properly enrolled in early intervention, received amplification. However, despite numerous early referrals for CI, they weren't implanted until age 8 because the parents just felt the hearing would spontaneously improve. And despite numerous conversations and discussions to the latter, they just would never kind of move forward. Socioeconomic and structural components are definitely a factor. We had 2 patients that had all of their care at our public city hospital. Both were delayed, one because they were moved between different family members, different cities, and had heavy involvement with social services, and they weren't diagnosed with profound hearing loss till age 3. And a second child who also failed their newborn hearing screening and just never followed up until age 4, unfortunately. And then the third group, looking at inadequate guidance from previous providers. There were 4 patients in this group, 2 that weren't referred for a period of 1.5, 1.5 years, and 4 years respectively, despite meeting criteria. There was no clear reason that change took place, and the provider finally referred. and another 2 patients that were wrongly told that they weren't candidates for CI because of their anatomy, because they had mild cochlear dysplasia, which was untrue, and both were implanted late. So the second group that we looked at that we thought we could intervene on were those that were not subject to newborn hearing screening. In our cohort, there were actually 8 children that came to the US later in life and were ultimately delayed because of either identification of hearing loss, delayed amplification, and then that ultimately resulted in later cochlear implantation. The 5 that we felt could have been helped sooner when they arrived to the US are bolded here in the chart. The other 3 were actually appropriately diagnosed and referred for CI in a timely manner from when they came to the US. So I know I've presented a lot of different data from different studies, and I feel like it can be a little dry sometimes. And the best way to really think about this topic and where I think it's useful for everyone is to think about the different barriers and how they affect timely cochlear implantation and how they affect our patients is to do it visually. So to do so, I adapted the Anderson's model to access to care for this purpose, is for this patient population. And I think as providers, whatever the specialty, whatever the patient population, we need to develop this cultural competency to be cognizant and empathetic to these different patients and the different societal and structural factors that contribute to how a individual patient interacts with the healthcare system, interacts with us, and ultimately reaches our desired goal of, for this population, early hearing aids and early cochlear implantation. And ultimately, understanding all these barriers can help us identify what the interventions are, where we can intervene, and what the solutions to delayed care are. I'm not going to belabor each point for purpose of time, but you can kind of get the idea. So kind of using that as my model, started thinking about where we can intervene. And I think definitely one area is to have a truly universal mandatory newborn hearing screening. I think in most of the later studies that I presented that would have captured a handful of patients. I think better outreach to referring providers and audiologists is huge. I think especially those that are outside of big centers, making sure they understand what the criteria are so that we can get these kids in sooner. As discussed, I think fostering better cultural competency amongst those of us that are taking care of these patients so we can really better address their needs and understand what their potential hesitancy might be and if that's actually what's driving their delayed care. A second screening point before the end of the critical period could definitely help improve these delays. Nearly half of the children in our study would have been captured by a second screening. The University of Pittsburgh did a recent study that was looking at 78 children over a 10-year period. Half of those were found to have severe and profound hearing loss. These were all kids that actually passed their newborn hearing screening and then diagnosed later in life. Their average age of diagnosis was then 4.5 years old. So a second screening point would have definitely been optimal to reach many of those children. And then some kind of final take-home points that I wanted to kind of hit home. And I think one of the biggest things is that pediatric hearing loss that requires intervention is unfortunately extremely common. We really know that early CI leads to better outcomes for these patients, and we clearly have lots of room for improvement to reach these children. The different studies have kind of talked about the different contributing factors that lead to the disparities in timely cochlear implantation. Where you live matters. We have inconsistent newborn hearing screening. Referring provider knowledge is sometimes inconsistent. And then we need to think about the different socioeconomic family dynamics and how race plays into how people are accessing the healthcare system. And I kind of bring home back my Anderson's model because I think this is probably the one big take home is to think about whatever our patient population is, to look at it through this lens. Because I think regardless of what we're treating, this matters. And we need to think about the different factors that really impact a patient's experience with the healthcare system. Um, and ultimately, that allows us to understand the problem so that we can identify ways to intervene. As I mentioned in the introduction, only 36% of infants that need implants receive them, and we can clearly do better. Thank you very much for your time, and I can take any questions if we have time for that.
Thank you, Steve. Thank you, Dr. Ford. This is great. We have perfect. We have about 5 minutes of time for fill some questions. The first one that I wanted to, if it's okay with Alice, right, just to get things started. This is a big issue in the United States, and I would imagine, Steve, that this is even potentially even a larger issue around the world. You have an idea about the scale and the magnitude of this problem around the world?
I mean, I know globally it's huge, and I think we even saw that in our study because we had 8 patients that were just coming to New York City area that came to our institution that weren't screened, weren't diagnosed really until they came to the US. And even then they were delayed. I don't know the exact numbers, but I know this has been studied pretty well in Europe as well. That's where the universal newborn screening has come from. They've actually started, there were a couple systematic reviews looking at having a second screening point in Europe, which they found to be cost effective as well. So it's, and these kind of talking about more of the developed countries, but we know that the burden is actually worse in developing countries too. So it's really not just the US, but unfortunately that was just the focus of what I had time for today.
And I was just going to say, Steve, given the cost of these implants, that problem is exacerbated in developing countries. And I guess that's a follow-up to the question, what kind of things are there been any inventions, anything that will make this more affordable to other parts of the world that we can go ahead and do, just like what you guys have done with cleft palate, right? This is becoming, still a big problem in the world, but it's more doable. People can come in and do tons of work and be able to help with people. Anything in that sort of space for this?
I can't say that there's anything very definitive. I know that was something that is kind of at the forefront in terms of trying to make this affordable in those countries. I know at NYU, we work closely with Uganda. Dr. Rowland had been going there for a while and trying to at least make them a little bit more independent. So he had gone to kind of teach instead of a traditional medical mission style where they come in and do the surgeries. It was more to get them up to date, kind of start a residency for them so that they can do the implants. And I think they've worked on bringing the cost down, but I don't think we're quite at a point that we have the capability to do CIs at a cheaper cost at this point. I think a lot of times it ends up being hearing aids and trying to get those to those areas.
Amazing. I see a question from Dr. Olum. Dr. Olum, you want to ask a question?
Sure. So the question I had was, how do you address hesitancy for the cochlear implants in different populations? Because even in adults, we see a lot of hesitancy to put on a hearing aid. I can imagine it's even greater for children and an actual surgical procedure.
So the hesitancy really becomes more from the parents. So I definitely see where you're coming at with that. And obviously we saw that in our studies. And I think the biggest thing is having the time and making the time to understand what the patient's perspective is. Why are they hesitant? What are they worried about? And then try to address those. And not making assumptions as to why they might be hesitant or what their theories might be. We have to ask them. We have to really talk with them, sit down with them, and communicate why this isn't so important for their child to either have a hearing aid or to be implanted, how that's going to affect their educational opportunities and their their quality of life. And I think that's why I have that Anderson's model, because there are so many factors that are going to be involved, and we have to be able to find time to have those conversations with patients. It's only going to be through education that we're going to be able to reach them.
A question. Dr. Gordon, thank you so much for presenting this information today. I think it's quite powerful as far as showing where there's a gap between people should get the delivery of care and are actually getting the delivery of care, if at all. Since you have this information sort of in hand now and have done a nice study to kind of show where some of the breakdown is, and also can see on your heat map where there could be room for improvement, what avenues do you sort of see as pathways for advocacy for your patients, like on a national resource? Like, basically now that you have information, where do you see as the next avenue to use that information?
I mean, I think I wouldn't say it's an easy way, but I think one of the big ones is legislatively, if we could actually push that. I think having, as I said, a real mandatory newborn hearing screening, so that we are doing that for every child that's born.
Is there a way to do that through like the American College of Surgeons, or through our own academy, to try and advocate for those patients?
I mean, I think yes, and then you have to do it locally within your Congress people and really lobby, because I mean, we can try and go state by state, and I think that's an option. I think if you had a federal mandate, and I think in probably this climate that might be a little bit difficult, but I think that this is such an important topic that okay, fair enough, that I think there should be enough support. It's a simple screening method that's been shown to be cost effective for society. And then I think having a second screening point, whether that's even just school making sure that they're testing the kids or sending them to their primary care doctor. I know it's difficult, but I think that's where we need to be putting a lot of our focus.
Great.
Thank you. I see Dr. Breen. Joe, go ahead. Take it, and then Greta after that. Go ahead, Joe.
Okay. Hey, Dr. Gordon. Thanks for your talk very much. For your kids in your study in New York, do you have any follow-up on the outcomes for those who had that cultural hesitancy, or the parents, if they were not engaged or convinced to come for earlier referral? Was there good engagement and follow-up and outcomes for these kids after they were implanted?
In terms of the outcomes, we do have them. Ultimately, the later implanted group did perform worse than like our historical controls and those that were implanted earlier than 3. We didn't want to make any huge kind of assumptions or conclusions based on that, just because we know there are so many other factors besides just delayed care in terms of how kids do. I'd say half of the kids that were implanted late were pretty good users, had good speech scores post-operatively, but the other half, I don't have the specific stats I think in front of me, but I would put them in like the moderate range. They did okay, but on average, they did a lot worse than the ones that were implanted earlier.
Greta, you want to ask your question?
Yeah, if there's bandwidth, I'd like to ask one.
Yeah.
All right. So very nice presentation. That's one that's near and dear to any audiologist or otologist's heart. It's a wonderful story of augmenting a damaged neurosensory system to improve health in a very meaningful way. Looking at the environment, you in your model, you have everything centered around the cochlear implant team. Have you looked at the cost and reimbursement rates for stages between screening and going to a cochlear implant center? So for instance, if you fail a hearing screening, you go to an audiologist. Is that covered by insurance, Medicare, Medicaid? And you have to do that several times before you would fail enough to go to a cochlear implant center. So your a society's priorities are in their budget. And I would venture to say that most of the time, those appointments are not covered, which is a huge hurdle when the provider is not local, or when the provider is wanting to be local, not affiliated with a large center, but doesn't have the financial underpinnings to provide a service out in rural America. So I'm pontificating rather than asking a question. I'm sorry.
It's okay. It's a very important point I
That's-
think that you bring up.
We have to stratify that environment a little bit more carefully to really nail some of the problems with our management of hearing impaired people.
And I think that's probably why the Kentucky group has seen such a disparity between rural and urban patients, is because of that exact problem. And I think that would be a great area for me to start investigating as well. So I appreciate that.
Sorry for
No
pontificating.
problem.
Great points. One more question from Greta, because I wanted to make sure that I got to. Greta, go ahead and ask your question, please.
Thank you. So my question kind of piggybacks a little bit on Dr. Zappala's, but obviously one of the biggest barriers is, early implantation and early access to care. But even if they do get beyond that step, with a cochlear implant, it's not necessarily a one and done. There's a lot of follow-up maintenance. There's a lot of ongoing required care, that sort of thing. And so do you see some of the same barriers, even if you can get early implantation, in terms of following up over time and making sure that things continue to progress for these children?
Absolutely. And I think the Case Western study was actually kind of talked to that point, where Medicaid didn't necessarily have an impact on whether or not the kids were got hearing aids or implanted sooner, but they missed multiple more follow-up appointments. They missed consecutive appointments. And I think that's a huge factor, because ultimately they might not get optimized like they should. They might not do as well. They might not become full-time users because of that. And I think it has a lot of downstream concerns that I think you bring up a great point. So, yeah.
Thank you.
Wonderful. Thank you, Steve. And thank you, Jeff. And thanks everybody for the wonderful presentation. Great opportunities. I would just leave you with one thought in neurosurgery, hydrocephalus, the implants that we put nowadays, the valves are programmable and they are extraordinarily expensive. It turns out that the generation before, they're just flow and they are much less expensive. And they are extraordinarily successful in alleviating hydrocephalus, which happens to be a tremendous problem around the world. And I think that they are making those much more accessible for the rest of the world. So there are, that's what I was wondering, whether or not the technology can be, somehow be made more affordable, So something to consider in the future. And this is a big problem for what I understand from you. So thank you for your presentation. We're excited to have you and have a great rest of your day.
Thank you so much. I appreciate it.
Thank you.